So now we're going to sort of, I guess we'd say, turn to the treatment issues. So very specifically, Tate, what is your preferred approach to the platinum-sensitive recurrent disease setting, the partially platinum-sensitive disease setting, and finally the platinum-resistant setting?
Dr. Birrer said I should give a one-word answer, so yes. But beyond that, though, just to define these quickly, Dr. Markman actually was one of the two people that's responsible for defining this phenomenon. We consider somebody platinum sensitive if they've had a response to initial therapy and gone at least 6 months before they require retreatment for recurrence and progression of disease. Other patients we classify as resistant. I don't like the term partially platinum sensitive, which some people use to describe a patient with a 6 to 12 month treatment-free interval. For platinum sensitive patients, we retreat the patient with a platinum-based regimen, usually a carboplatin-based doublet, either Taxol carboplatin, gemcitabine carboplatin, or Doxil carboplatin, all three of which have been vetted in phase 3 trials. If the patient responds and goes 6 months again or more, we will retreat them again until they prove themselves clinically platinum resistant. For the platinum-resistant population, which are those patients that are not platinum sensitive, we treat those patients with a single chemotherapeutic agent plus bevacizumab based on the results of the Aurelia trial that was published recently. Adding the bevacizumab has an advantage over single cytotoxic agent. We don't have any evidence that combinations of cytotoxic agents in this setting offer an advantage, and our preferred regimen there would be weekly Taxol plus bevacizumab.
Very reasonable.
Yeah, I mean, that's almost identically the same approach that we have at our institution. So.
And the only thing I would add to that, obviously a lot depends upon the questions of the previous toxicity the patients have had.
Oh yeah.
So if somebody's had a lot of neuropathy, I love weekly Taxol. It's a great drug, but that's a drug that you'd probably want to stay away from it in that setting. But again, it really depends. So a question that has come up, and particularly now that we actually are seeing ovarian cancer as much more of a chronic disease process where patients may get a number of regimens, is platinum resistance reversible over time? Mike, do you have a feeling on that? Is there data? Is there laboratory data that says that?
So that's a one-word answer?
Yeah.
No. So this is sort of the holy grail. I mean, as you know, the development of platinum resistance is really an important event in this disease and makes the disease extremely difficult to treat. So overcoming platinum resistance or reversing it or delaying it is an area where both laboratory-based individuals and clinicians are really focusing. From a lab standpoint, I don't know of any substantial evidence to suggest that platinum resistance can be reversed. And that doesn't mean that there aren't ways to treat platinum-resistant cell lines and clones within the lab. There are other targets that may make the tumor responsive, but that doesn't necessarily change its response to platinum. But the real experiment, if you will, is in vivo in patients. And this has actually been extremely difficult to test because, as you know, recently we haven't had a lot of non-platinum either combinations or drugs that would give us that window to see if the tumor then became platinum after a substantial amount of treatment. We now may be at the point where we can test that with agents like bevacizumab and others, where we can have patients who go on for a year, 2 years, or 3 years after developing platinum resistance. We can fundamentally then come back with platinum and test whether the tumors have become more sensitive. But I think a lot of us are concerned that this is either epigenetic phenomenon or a genetic phenomenon, and it is fundamentally not reversible.
So, I mean, the only data that I'm aware of are from trials evaluating DNA methyltransferase inhibitors like decitabine. You could even say that gemcitabine is chemically similar, where there's some inkling of evidence that that you can partially reverse platinum resistance, but we haven't gotten to any randomized trials, and that whole area of research is moving along incredibly slowly. But I was encouraged by at least phase 2 data related to that class of agents.
Didn't GOG actually, well, we did. I mean, we had a phase 2 trial of gemcitabine cisplatin in platinum-resistant patients to see if that combination would result in a response rate more than what single-agent gemcitabine would give, and in fact it didn't. It gave a response rate that was essentially identical to what we got with single-agent gemcitabine. That would tend to suggest that using gemcitabine in combination with a platinum compound does in fact not reverse platinum resistance.